All right, ladies and gentlemen, welcome to this session, How to Explain Statistical Analysis to the Clinical Cardiologist, Non-Inferiority Trial, Subgroup Analyses, Composite Endpoints, and Meta-Analyses. I also welcome not only people here in the room, but also on the net, and I'm amazed how many showed up. You know, in the old days, the Prime Minister of Queen Victoria, Benjamin Disraeli, said there lies, damn lies, and statistics. But now we went far, and we start to understand that this is truly important. And in fact, for publication is also very important. And at the European Heart Journal, we hire a whole team led by Sabine Murphy to make sure that these questions are appropriately addressed. And I think so it's very important for all of us to understand it when we read it, and even more so when we write it. So I'd like to introduce Dr. VIDAL PEREZ from Santiago de Compostela, who will introduce the concept of the meeting.
Yes, thank you for your presentation. We are very glad from the Cardiologist of Tomorrow to host this session. It's have to remember you that it's an interactive session with chat, so you can send the questions to our virtual audience, and also by Twitter if you are inside of the room or you are outside, you want to get up to get the microphone. So we can start now. I start presenting the first speaker, Xavier Jouven. Come to the podium, please.
Thank you, dear Chairman. First I want to thank you for organizing this session, and Dr. Cavallo with the young cardiologist to organize this, and also to have Thomas Luscher with us. It's showing you that it's very important for European heart research to have statistical presentations, and since you are very numerous and nobody will fill the room, so we will have to open another room. And thank you to be here, and I will try my best not to make you run away. And so I'm Xavier Jouven. I am a cardiologist and epidemiologist, and I am running a research unit of cardiovascular epidemiology in Paris, and we make a lot of fun. I will try to share this with you. And first, you're exactly right to be here today, because look at this. Of the non-inferiority trials. When you look in the PubMed search, when you see that there is an exponential increase in the number of articles published when you choose non-inferiority or non-inferiority trials. So there are more and more non-inferiority trials during the last year. So why? Maybe we can have a discussion later on this. It's very important also. But first, I would like to address what is a non-inferiority trial. And first, we have to go back to a superiority trial. The superiority trial, like the name is, you want to show that the response for a new drug is clearly, significantly superior to reference treatment. That's the superiority trial. The equivalence trial is that you want to show that between two drugs or more, there is no real important difference if you stay within a certain margin, which is the equivalence margin. You choose the equivalence margin with a lower and upper boundary limit. That's the equivalence. The non-inferiority trial is when you want to show that a new treatment is not clinically inferior to the reference treatment within a same limit, an inferior margin, and you have only a lower limit. So you see immediately that if you cannot reach the conclusion of the superiority in a superior trial, it doesn't mean that you can conclude to a non-inferiority. And also, we will look at this. Here you have the difference between the two drugs. If you have a superior trial, you want to show that there is a superiority. Okay, there is the difference is significantly different from zero. And if you have a non-inferior trial, you choose this difference, you accept this loss of efficacy, and you have to show that your new treatment is just between 0 and this lower limit. the equivalent trial is you have limits, a lower limit and an upper limit. So, in other words, a non-inferior trial is a unilateral equivalent trial. You see, just with the lower limits. Okay, immediately let's have some example. And you see that the definitions are quite clear. However, there are many mistakes, even in very good journals. For example, this one, the Gusto 3 trial, which was a very important trial, Gusto, comparison of reteplase and alteplase for acute myocardial infarction. And as you can see, this study has been done in more than 15,000 patients in 20 countries. And in fact, it was a superiority trial design, and they show that the mortality rate was 7.47% in the reteplase, a new treatment, compared with 7.24% in the alteplase group. And so they were unable to conclude to a superiority. And that's true, that's exactly what they said. The chief finding of this trial is that reteplase is not superior to alteplase for the treatment of acute myocardial infarction. And I completely share this conclusion. However, as you can see, a few sentences below, they changed slightly the conclusion by saying our finding of the similar efficacy of reteplase and alteplase. This is the main and the most frequent mistake, and very important mistake, that people do with non-inferiority trial, is the interpretation of the result. When you cannot reach a conclusion of superiority, it doesn't mean that the treatments are similar. It's very important. When you want to establish non-inferiority, you need to have 3 points. The first one is that you want to show that your new treatment is non-inferior to the reference treatment. Okay, that's clear. But the second one is also, and you need to have it, that you still have, with your new treatment, a superiority versus the placebo. And third, this new treatment, you accept a loss of efficacy, but in fact, you want to gain in terms of ancillary advantages such as safety, convenience, cost, and so on. Okay, that's the 3 criteria. Why the second one is also very important? Because, for example, you want to show that the treatment A, a new treatment, is non-inferior to a reference treatment. And you perform a good, well-designed study, and you show that A is non-inferior to the reference treatment. And then another team, or maybe your own team, want now to show that treatment B is non-inferior to the reference treatment, but you say, okay, now I can choose treatment A. And if you do a non-inferiority test, you can conclude, yes, B is non-inferior to A, but however, here you see that B is not anymore different from the placebo. So be careful of successive non-inferiority trials that will lead you directly to the placebo. Now, what are the characteristics of non-inferiority trials? And as you will see during this presentation, much of what is the most important is only a good mind. It's not very complicated. It's not statistical. It's more clinical judgment than statistical criteria. And the errors are also on the clinical judgment more than statistical criteria. You have to carefully choose what is your reference treatment and what is the expected rate of the outcome in the reference treatment against the placebo. So you see, but it's obvious. We know the decrease in mortality for the reference treatment, for example. It's not so easy because usually you have many studies and they do not have exactly the same result. So usually you need meta-analysis to choose the expected rate of your reference treatment against the placebo and also the confidence interval. And with the new treatment, you also have to decide what you expect to be the event rate of your new treatment and also its confidence interval. You also have to choose between a design, intention to treat, or on treatment, and we'll see that it's not the same. Intention to treat is better for a superiority trial, or through on treatment is better for non-inferiority trial, and we'll see why. Also, obviously, you have to choose what is the most important is what you will accept as a limit for your non-inferiority. This is a loss of efficacy, and this loss of efficacy, the maximal loss of efficacy that you are ready to accept, will depend on, obviously, the seriousness of the outcome. If it is mortality, you will not accept a very important loss in terms of efficacy. If it is less serious, maybe you can accept a more important margin. All through, it will be related on the magnitude of the standard treatment effect, but also on the ratio, on the risk ratio between the benefit and the safety, the convenience, and also the cost. You have also some statistical criteria that are not very complicated, don't be afraid, but there is immediately one limit. We were talking about meta-analysis. If you take a meta-analysis to decide what is the rate of outcome of your reference treatment, that's the correct way to do. However, even using this method, you will probably have some bias, and I give you one, which is the temporal improvement. For example, mortality for myocardial infarction has been decreasing over the past 30 years dramatically. It was 40%, now it's 7%. So if you have a meta-analysis taking, I don't know, the last 10 years, you will have this temporal improvement that will change a little bit what you expect today compared with what you had 10 years ago in terms of mortality rate and efficacy. Second point is that usually we accept the 50% rule, which is that we accept and we have to choose the limit, the lower limit of the risk difference has to be 50%, half of the 95% of the confidence interval. We'll see an example. Also, usually we prefer to have a fraction of the standard treatment effect to be preserved, around 20, 25, but not more. We don't want to lose more than 25% of the efficacy of the reference treatment, usually. And since, as you understood, it is a unilateral test, non-inferiority is a unilateral test, we have to use a first type error of 0.025. So we'll build together one example. We'll build your first non-inferiority test. We have a new treatment, N, and a reference treatment, A. And we have to choose, and we have no time to discuss it, but anyway, we accept a loss of efficacy of 25%. Okay? It's big. Huh? And for example, the new treatment, we accept to lose 25% of mortality rate. And according to meta-analysis, we have been all looking at the articles published, and we expect to have in the reference treatment an efficacy as a decrease by 4% of the mortality, and the confidence interval -2 to -6. Okay, that's what we get from the already published article. Huh? Okay, what does it mean that a decrease of 4% with the confidence interval between 2 and 6? That means that in the worst condition of the reference treatment, the minimum efficacy of the reference treatment is a decrease of 2% of the mortality, since it is the lower limit of the confidence interval. Okay? That's the reference treatment. Since we accept a loss of efficacy of 25%, that means that we will accept an increase of mortality, of absolute risk of mortality, of 0.5%. Okay? It's very easy. Okay? So, when you will look at the difference between the new treatment, N, and the reference treatment, A, since we accept 25% of the mortality, of the efficacy, loss of efficacy, it means that in absolute difference, we'll accept an increase of 0.5%. Okay, it's only 2% times 25%. So, that's what we decided all together. It's our new non-inferiority test. Okay? So then, now, we got the result. If we observe an increase in mortality of 0.9%, what is your conclusion? Yes? It's more than 0.5, and you are not ready to accept such an increase in mortality with your new treatment, so we cannot conclude to a non-inferiority of N versus A, since 0.9 is higher than the accepted maximum margin that we chose. We chose 0.5%, okay? Okay, so that's quite easy, you know? Okay? Okay. So we continue. Now, if we observe an increase in mortality of 0.3%, what is your conclusion? You conclude to non-inferiority, but you are wrong. That was a trick. Because you need absolutely to know the confidence interval of the 0.3. Okay? If we have a confidence interval between 0.0 to 0.6, then 0.6 is higher than the maximum limit of 0.5. So in this case, you cannot conclude to a non-inferiority. Okay? So be aware of this. It's very important. On the other hand, if we observe a confidence interval between 0.2 and 0.4, it is within the 0.5 maximum limit of the mortality increase that we are ready to accept. Okay? So, what is the conclusion? So we accept the non-inferiority. Don't tell me that they are similar, because the true conclusion is yes, and the new treatment is non-inferior to A, the reference treatment, if we accept a proportional 25% increase in mortality rate, which is huge. Okay? So in no way accept in the conclusion of a non-inferiority test, even if it is positive, okay, if it is non-inferior, never accept the term of similar, equal. We will never be able to show any equality in terms of statistic. But even similar doesn't accept it, because you accept a 25% increase in mortality, which is huge. Okay? So now let's have a true example in another very good review. And this was a trial to compare ximelagatran with varfarine for stroke prevention in patients in atrial fibrillation. And according to what has been published on varfarine, the event rate that was chosen according to meta-analysis and already published trials was 3.1% per year of stroke. Okay? And the others accepted a non-inferiority margin, but absolute margin, not relative margin, but absolute margin of 2%, which correspond to 95% of the lower limit of the absolute risk difference. from the trials. And this was taken from the literature. And they decided to have a design intention to treat. What are the results? They observed an incidence rate per year for the warfarin 1.16%, much lower than the expected one, and ximelagatran 1.61%. So the absolute difference was 0.45% with the confidence interval, as you see, less than the maximum 2% that they wanted. So they conclude to non-inferiority. And clearly, they say ximelagatran was non-inferior to well-controlled warfarin within the specified margin of 2%. And if we had chosen, instead of 2%, if we have chosen 1%, the probability of rejecting the non-inferiority then was 0.01 for the 2%, and then for the 1% margin was 0.06. So non-statistically significant, but okay, very nearby. So it is good journal, but very poor trial. And I will show you why. For different reasons, not only for one, but for many different reasons. First one, they have chosen an intention to treat design, okay? You see here, in every arm, ximelagatran and warfarin, you have more than 1/3 of patients who discontinued the treatment. They change arm or they stop, okay? In the non-inferiority trial, you understand immediately that if you have a very large amount of subjects or patients who change arm, then you will increase the risk to conclude to a non-inferiority because the patients will be the same in both. They change, okay? So it's very big risk. So, opposite to superiority test where intention to treat are the best design, on non-inferiority trials, it's much better to use the own treatment. You understand why? Okay? Second, obviously, they observed 1.16% and they expected 3.1. And this is also a very important mistake because if you expect a certain amount of percentage of efficacy of the reference treatment and you observe a much lower efficacy, then you understand also that it will be really in favor of a conclusion on non-inferiority with your new treatment. So it's very important to be careful in the choice of the efficacy, the expected efficacy of the reference treatment. Again, they did not use the 50% rule, but instead they use only the 95% lower limit of the risk difference. If they have chosen the 50%, they would have chosen 1% of absolute risk decrease instead of 2. In addition, it's better to think in terms of relative risk than absolute risk. And you see here, because they have observed 1.16% of outcome, and they accepted a loss of 2%, absolute 2% decrease of the efficacy, so less than 0. Okay? So it's better to use the relative risk rather than the absolute risk. So this trial, it was not the conclusion of this trial, they were not able to conclude to a non-inferiority. However, they did. And this is my last slide. I want to show you that there is like a mirror. There is a mirror between superiority trial and non-inferiority trial. If you look at the potential errors and bias, if you look at the first type error, which is the risk to conclude artificially towards superiority in a superiority test, and the risk to conclude artificially towards non-inferiority in terms of non-inferiority test. Let's look. Okay, we have seen intention to treat. Intention to treat is when you use intention to treat, then you decrease slightly your power to show a difference if people are changing arm, okay, in intention to treat. But intention to treat, we have seen it, will increase the bias, the risk to conclude artificially toward non-inferiority. Specifically, a large amount of subjects change arms, we have seen this, okay? Also, if there is an important variability in your study, then the power to conclude to a superiority will decrease. However, it will be in favor of non-inferiority conclusion. Again, if there is a large confidence interval, it will be very hard to conclude to a superiority, but it will be also in favor on a non-inferiority conclusion. If you have a very bad quality of the measurement, it will be very different to show any superiority of the new treatment versus the reference treatment. But it will be in favor to a conclusion of non-inferiority. And if you expect a big difference between both treatments, it will be very difficult to reach a superiority conclusion, but it will be easier to show and to conclude to a non-inferiority conclusion. And if you have an insufficient sample of patients, that you will be unable to reach superiority, but it will be all again in favor of non-inferiority. And non-inferiority trials require more patients than superiority trials. So, in summary, every step of low quality of the study will conduct artificially to the risk to conclude artificially towards a non-inferiority. So be really cautious in the methodology against more than for superiority test, because every step that are sometimes that can be voluntary yes or no, consciously yes or no, hidden by the authors, every bad step will conduct artificially towards a conclusion of non-inferiority. So this is very important for you to look carefully at the methods section, and I'm sorry for it, including the statistical chapter, because you will understand exactly what is the design of the study. Thank you for your attention.
Thank you for your presentation. We will move on to the next presentation. How to access and to interpret composite endpoints. Are there better alternatives? Professor Pocock.
Thank you. What do we do here? I'm sure somebody who knows will help me get into my talk. Is it obvious? Do I keep clicking? Oh yes, I keep clicking. Sorry. As a statistician, you will be pleased to know I never use a computer. You mature out of such things. That doesn't mean I make up the numbers. That's another matter. So anyway, let me just get organized here. Right, well, that was a good start. With methodology sessions like this, I'm used to talking to an audience of size anything from 2 men and a dog upwards. So it's delightful to see so many of you here, and I'll try and make it worth your while. So how to interpret composite endpoints, and are there better alternatives? It's going to be a quick review full of examples, which I hope is relevant. Composite endpoints. Well, we need them because individual components, such as cardiovascular death, are insufficient to give us adequate statistical power. We hate them because they combine components that vary a great deal in their clinical importance, and treatment effects will vary across those components. And therefore we often abuse them in giving an oversimplified interpretation of a more complex pattern. And always, my main message is we should explore the details of the components as well as the composite overall. They're very common, so a recent survey showed that of cardiovascular trials that were published, 73% of them had a composite as primary. Typically 3 components was quite common, and they nearly always include death and myocardial infarction, which is no surprise. So we're dealing with something that's very common in our field. They generate confusion. Here's an example. The PEREZ trial in diabetes, pioglitazone versus placebo, a large trial, had as its primary, ended up with a result for death, myocardial infarction or stroke, a very common composite, as a statistically significant result with fewer events in pioglitazone compared with placebo. But the primary endpoint, they thought they would gain power by adding more into the composite. So the primary endpoint also included ACS events, endovascular surgery or leg amputation. But those extras added nothing except numbers. They didn't add anything in terms of distinguishing between the treatments. So the primary gave a borderline significant result. Needless to say, the authors wanted to put post hoc emphasis on the secondary composite, commonly known as cheating. So it needs to be remembered when you're constructing a composite, adding in more and more events doesn't necessarily help. It may destroy what you're trying to achieve. Let's look at another quite common type of device trial or drug stent trial, drug-eluting stent versus bare metal stent trial in primary PCI called the Typhoon Trial. A typical primary endpoint in that kind of trial was a composite of cardiac death, myocardial infarction, and target vessel revascularization. And for this composite, sirolimus versus control stent, you got a highly significant result. There were far more primary event patients with a primary event in the control group. But this, if you say it quickly, primary endpoint is cardiac death, myocardial infarction, and target perivascular. You think it's all about cardiac death, but it's nothing like that. Because there are very few cardiac deaths, very few myocardial infarctions. And the whole story is driven by the third component, target vessel revascularization. We tried to learn from this in designing future trials, so the Horizons AMI trial of somewhat the same question separated the primary efficacy of target lesion revascularization at 1 year, having that stand alone, and then have a composite of patient-oriented safety issues of death, reinfarction, stroke, and stent thrombosis looked at separately. And then what happened is what is entirely logical. The efficacy is about the lesions. Target lesion revascularization was less common in the drug-eluting stent, so success in that sense. And you saw the patient-oriented issues of death, reinfarction, stroke, and stent thrombosis, there was no difference. And so I think this is a way forward that they've learned in drug-eluting stent trials, is to separate reintervention from the major clinical concerns, and that's helpful. You need to interpret composite endpoints with great care, and the Syntax trial, which now has 4-year results, well, it will in a month or so's time be presenting 5-year results at TCT. It was a trial in patients with left main and 3-vessel disease comparing bypass surgery with a drug-eluting Taxus stent. Now, the primary composite endpoint was commonly called MACE, which comprises death, stroke, myocardial infarction, and repeat revascularization. But using that as your primary conclusion, it did not capture well what was the complex picture that was going on. And Cardiovascular News at the time concluded the Syntax trial fails to show non-inferiority for drug-eluting stents. A bit dismissive. So let's look at the actual 1-year results in a summarized form. The MACE did indeed turn out to have far more events in the patients having the event in the Taxus arm than the bypass surgery arm, very highly significant. But the devil lies in the detail, though, and we need to look what was going on in the subcomponents. So we see for death there was no evidence difference at 1 year. Stroke was going significantly the opposite direction, more strokes early on in bypass surgery. Myocardial infarction, a weak trend towards more in Taxus. But combined, nothing going on with those three. But revascularization was entirely driving the conclusion in that trial, with vastly more than double the revascularization incidence in the Taxus arm. But then you look at the detail there, and you see that most of that is just a repeat PCI. Many patients would say having 2 PCIs is less invasive on you than having surgery. In fact, one retired cardiologist who's had both said that he wouldn't mind having 6 PCIs compared to bypass surgery once. So it's a complex picture which the primary endpoint didn't really capture. Looking at 4 years, this is supposed to be the main conclusion out to 4 years. You see more MACE events in the Taxus arm than in the bypass surgery arm. So you're now asking yourself, well, what was it in the MACE that is driving this at 4 years? The situation has changed. Now things have developed so that you have a borderline significantly more deaths in the Taxus arm out to 4 years, more than double myocardial infarction, and stroke still trending the wrong way, and still more than double the revascularization rate. So this has a message about 2 things were wrong in syntax in pre-planning. It was a good trial. I'm not attacking the trial, just the conclusions. The 1-year conclusions were not helpful. We now see that 1 year was too short, actually. So you can have the most wonderful composite, but if you don't study it for long enough, you don't get the real answer. And the real answer is, in the long run, stenting is not doing too very well in this population. You have an increase in MI, an increase in revascularization, and a suggestion of an increase in mortality. Strokes are the one exception. So what we've learnt from this is you need to see the details like this, and you need to follow patients longer. So another somewhat related trial, the XL trial now going on, has its primary endpoint out to 3 years. And that's the sort of duration we need in this sort of trial to come to wise conclusions. So the essential message is always pay attention to the individual components when you're looking at a composite outcome. Now I'm going quite quickly, so I'm skipping things which you may read, but they're not that important. So we'll just keep going through what I think the messages I have. So now I'm turning to novel ideas. How can we do better than the conventional composite? Sanjay Kaul and colleague has suggested that we could consider weighting the components. So if you've got a trial with death, stroke and MI, you know deaths are somewhat more important than strokes, and both are probably more important than MIs. But do you really want to do an analysis weighting them like this? I think it's interesting conceptually, but I don't think you get away with it as a major way of weighting endpoints. Though the 3 I'm going to talk about are days alive and out of hospital as one approach. In chronic disease, why not begin to use repeat events rather than just the first event that happens? And then methods that can recognize that you need to give greater priority to deaths in any composite, a new method called the win ratio. So that's a tall order to go through, so I'm going to go quite quickly. I'm going to use the CHARM trial to illustrate days alive and out of hospital. So that is, during follow-up, this for every patient in the CHARM trial shows the distribution of the days alive and out of hospital. And of course, down this end is the patients who died early and therefore they had a lot of time dead. And that's unfortunate. And up here, this is varying because of the follow-up time. So what you really need to do is look at the proportion of potential follow-up time that patients spent alive and out of hospital. And this is about as peculiar and tricky a distribution as you could hope to get. These again are the smallish number of patients who died early and died later. This is patients who probably spent a lot of time in hospital. And these are the patients who spent 0 or very little time in hospital. So days alive and out of hospital, you need to remember it sounds a nice idea, but its distribution is most peculiar. But ploughing on, we could look at the proportions of potential follow-up time in various states that the 2 treatment arms of the CHARM trial the patients were in. So we have the active treatment, candesartan versus placebo. There were more cardiovascular deaths on the placebo arm, and since the proportion of follow-up time, potential follow-up time that was in the state of having died from a cardiovascular disease was more in the placebo group, nearly 2% difference. Other deaths, no difference. Hospitalizations for heart failure, which in the normal primary endpoint made a major contribution, people don't spend that much of their follow-up time in hospital, thank goodness. So you're looking at tiny percentages. And the tiny percentage of time spent in hospital on candesartan due to heart failure, that is tinier than the tiny percentage in the placebo arm. but it's not contributing a lot. Other hospitalizations made no difference. So if you add up the major contribution following cardiovascular death and the small contribution due to heart failure hospitalizations, you get this 2% difference in potential follow-up time that patients were alive and out of hospital in the Cantor-Sartan arm. It's a highly significant result, but it's a rather small percentage. I think the answer is, in looking at this kind of outcome, most patients do well whatever you do to them. And therefore, that's why it's only a 2% difference. And that's not a bad message to take away, but it may not help in interpreting what treatment differences are. The patient journey is an idea of John Cleland, which not only you look at hospitalizations, but you look at time spent in different NYHA classes. And you can see through the CHARM trial here, we're showing that over time there was increased proportion of patients spending in class 1, and the proportion of time in class 3 and 4 went slightly down. And so could you add that into the story as well as the hospitalization death bit? Well, you can, but the results are again emphasized. This is the percentage of time by treatment group that patients spent in different categories. And you can see placebo patients spent slightly more time in class 4, slightly more time in hospital, and of course there were more deaths, so slightly more potential follow-up time that was denied because they had died. And so you can weight these and get a patient journey comparison, but again, it's descriptive. How much does it really help you understand what's going on? So days alive and out of hospital and the patient journey, conceptually they're valuable, but you've got these highly skewed distributions. I think they give too much weight to early deaths when you're analyzing the results, but it could be a useful description of the absolute patient benefit. But I don't think it's going to be a primary endpoint in any cardiovascular trials, but it's suitable as a secondary analysis. I think that's where it lies. Now let me go to the next topic, which we've been working on quite a bit, is how can you include repeat morbid events in the analysis of treatment efficacy? For instance, in heart failure trials, the usual conventional primary endpoint is time to first heart failure hospitalization or cardiovascular death, whichever happens first. So the repeat hospitalizations are usually ignored, as are any cardiovascular deaths that happen after they've already been hospitalized. And that doesn't seem right somehow. So we think we are heading in the direction of needing to agree methods that use all heart failure hospitalizations, which could lead to a gain in statistical power and hence smaller trial sizes. Let's have a go with the Emphasis trial. Firstly, a trial that had a positive result anyway. So if you look at the Emphasis trial of eplerenone versus placebo in patients with heart failure with mild symptoms, the primary endpoint was the usual heart failure hospitalization and cardiovascular death, and there were fewer on eplerenone than on placebo. And you can look at the numbers who had at least one hospitalization, 164,253. But if you look at the total number of hospitalizations, it was a lot bigger. And these extras are being completely ignored in usual analyses, as are cardiovascular deaths that happened after a hospitalization. So the primary analysis only used around 59% of all heart failure hospitalizations, and it included only 57% of all cardiovascular deaths. So we ought to be trying to do better. This shows the frequency distribution of hospitalization numbers over time for the two treatment groups, and you can see how there were fewer patients having 2 or 3 or 4, etc., hospitalizations on eplerenone compared with placebo. That's the motivation. This looks like a conventional Kaplan-Meier plot, but it's not. It's a plot of the cumulative rate of hospitalizations for heart failure, including repeats. And I think it's a graph that you might begin to see more often in publications for heart failure trials. And you can see how much eplerenone had a lower rate compared with placebo over time. And so, as I say, it's like a Kaplan-Meier plot, but it includes the repeats as well. But we can't just play with descriptive statistics like this. We need some inference, some estimates as well. So, using all heart failure hospitalizations, what's the best estimate of treatment effect? Well, you could just calculate the rate per patient year of follow-up in each of the two groups using what's called a Poisson assumption and do a rate ratio, which is 0.62, so 38% less hospitalizations per year of follow-up on a eplerenone compared with placebo. But that is slightly flawed because it doesn't take into account the skewness of the distribution of the number of heart failure hospitalizations per patient. Because some patients are very frail and will have lots of hospitalizations, but you don't want them to overweight the analysis. So you do what's called a negative binomial analysis, which, given more time, I could drive you into boredom and tears by explaining it properly. But it's a way of allowing for different patients' frailties. And then the rate ratio, oddly enough, is even greater. That will not always necessarily be the case, even greater effect. But the deaths are ignored in this analysis, and I'm going to come to the next example to see how we could incorporate cardiovascular deaths. The next example of this same methodology is in the CHARM-PRESERVE trial, because there's nothing like a trial that didn't make it with the conventional primary endpoint to motivate the use of repeat events. That's what happened in CHARM-PRESERVED. Patients with ejection fraction above 40%, the primary endpoint gave a hazard ratio of 0.89, which was not statistically significant. If you tried believing the investigators instead of the adjudication committee, that was helpful, but not wise, but still didn't get you there. It was still not quite formally statistically significant. But when you look at that same plot of cumulative rate of heart failure hospitalizations for candesartan versus placebo, you can see there's something going on here. That looks a very steady divergence. So if you repeat the analyses, you can see heart failure hospitalizations for CHARM, repeating the same style as I just gave for emphasis. You can see there are far fewer happening on candesartan than on placebo. If you go to the reasonably correct negative binomial analysis adjusting for different patient frailties, you get a rate ratio of 0.68 for hospitalization for heart failure, which is very, very highly significant with a fairly tight confidence interval. So that was what was missing in the opportunity to show that candesartan is indeed beneficial in preserved EF heart failure. Now, what about the deaths? You'd be criticized for saying we've only studied hospitalizations. My simplest solution to offer to you is to count cardiovascular death as the last event. So you add in an extra event for a cardiovascular death if it happened if it did not happen while a patient was already in hospital for their heart failure. And if you do that, you get a slightly more conservative result, but it's still highly significant. So planning future heart failure trials, and some are already in process of design using this approach of using all heart failure hospitalizations. There'll be a substantial gain in power, reducing trial size or length of follow-up. But the main task is to get agreement on the methodology, and the regulators, both the FDA and the EMA, are currently providing their input into what they think is the best way forward with this. They're receptive to the idea, but the details are still being worked out. Now, my last methodology is to say, when we're looking at a conventional primary composite endpoint, which has death and some other factor, why can't we somehow prioritize the deaths? Because at the moment, we prioritize the non-fatal event because it happens first, and that doesn't seem right. So this is a new technique called the win ratio, which is attempting to overcome that problem. The basis is you try and pair up patients, one in each treatment group, active treatment patient and placebo patient, try and find two at the same risk, the same overall prognostic risk, maybe a similar age, similar prognostic factors, and then compare them. So for any pair, who was the winner, who was the loser? Right? So if you died first, you could be called the loser. That seemed pretty obvious. Cardiovascular death. But in most pairs, neither of the patients died, in which case you then want to say, who was the loser on being hospitalized first? And so you untie the winner-loser concept, first prioritizing death, cardiovascular death probably, and then going on to hospitalization. And if it's a heart failure trial, you'll concentrate on heart failure hospitalization. So in a given pair, did the active patient win, lose, or was it a tie? And then the win ratio is simply across the pairs, the number of winners versus the number of losers in the active group. And that ratio can be easily calculated to give you a confidence interval. Let's try it. And here I'm applying the win ratio actually to the CHARM preserved trial again, looking at repeat hospitalizations as well. So I'm looking at 1,509 matched pairs, matched on risk, candesartan versus placebo. In 136 pairs, the candesartan patient had a cardiovascular death first and hence was the loser, but in 150 pairs they were the winner. But a lot of them, that didn't happen at all. Then you go on to win and lose on the basis of who had more hospitalizations for heart failure. And there was many more on placebo than on candesartan. So candesartan patients were winning here and losing there. And then there's a lot of pairs in which nothing happened. They were both okay, and those are the ties that don't formally enter the analysis. So the win ratio is for the candesartan patients, the number of winners, 150 plus 150, divided by the number of losers, 136 plus 106. A win ratio of 1.24, which it's simple stats, would you believe, to calculate the confidence interval and the p-value. So by using this win ratio concept, untying in this way, you could have come up with a significant result in CHARM preserved that was not achieved by the conventional analysis. The other approach to the win ratio is I don't like pairs. I don't like this concept of matched pairs. And some regulators have said that. So let's do it in an unpaired way in this example. The Partner B trial was a trial in patients who couldn't have surgery for aortic valve disease, who either had a transaortic valve implant, a TAVI, or standard therapy. And there was a massive difference on the conventional primary endpoint, but let's instead do what they chose as the main approach for this trial. Yeah, the win ratio, I'm almost there. The unmatched approach is you compare every TAVI patient with every standard patient. And so that's 179 patients in each group. So you have 32,041 pairs. And you look at each pair to decide who died first. And if that didn't give you a solution, then who was hospitalized first. And you'd then, across all these 32,041 pairs, you look at the pairs in which the TAVI won and the pairs in which the standard won. Compare the two, and it gives you a win ratio of 1.87. And so this is the unpaired win ratio approach, which I think also has quite a future in many trials to get away from conventional composites. There's the topics I've covered. I hope I've informed you, I've entertained you, I've probably confused you too. And one cardiologist advised me, a friend, that great talk, Stuart, but you included too many numbers. So sorry about that. Okay, I'll stop there. Thank you.
Well, thank you very much. We're certainly confused at a much higher level, and we progress to the last talk, which is what a clinical cardiologist needs to know to correctly interpret statistical analysis in meta-analysis. And we should be finished by 55, otherwise they'll kill us. Thank you.
Thank you. It's going to be a tough act to follow after those two excellent presentations. So let's start with an example. Do angiotensin receptor blockers cause cancer? This was a meta-analysis published in Lancet Oncology in 2010, looking at angiotensin receptor blockers and risk of cancer. The authors included 5 trials, and these were the results. Anything to the left of unity here, the controls were worse. Anything to the right, ARBs were worse. And what they found after meta-analysis of these 5 trials was the ARBs were associated with 8% increased risk of cancer compared to controls. And of course, media likes such news, and they immediately caught on to such things. This is what we saw in the Wall Street Journal. They say a new study said that a popular class of antihypertensive drug is associated with a modestly increased risk of cancer. And of course, we started seeing it in the New York Times, CNN covered this, CBS covered this, and of course, we started seeing it on the injury lawyer blog websites also. So these authors concluded this meta-analysis of randomized controlled trials suggested that ARBs are associated with a modestly increased risk of new cancer diagnosis. Following this, FDA and EMA decided to review the association of ARBs and cancer. Of course, it infuriated a lot of experts who said, wait a minute, there are a lot of missing data and this could cause adverse consequences. And rightly so, they said the media splash this paper could cause irreparable damage to the reputations of ARBs, and many can stop taking this medication, putting themselves at increased risk of cardiovascular and renal events. Of course, there was a lot of passionate opinions from many people who questioned why should Lancet publish this article. And some of them called this junk science. In the middle of all these, the value investigators came out and they said, but wait a minute, you did not include our data, and if you were to include cancer data from the value trial, the cancer risk with ARBs is completely abolished. So if you remember in the previous slide, there was a 1.2% absolute increase in cancer incidence with ARBs compared to controls, but if you were to add the value data, it would be 7.7% for ARBs and 7.7% with the other drugs. So a meta-analysis is like a sausage. Only God and the butcher knows what goes into it, and neither would ever eat any. So we decided, okay, let's take a look at this. I mean, we want to say, okay, so let's take a look at this, but also look at all of the antihypertensive agents, because the value investigators just in one trial showed that there was a 1.2% absolute increase in the risk of cancer with CCBs compared to ARBs, if you have to balance the ARB risk association. So let's take a closer look at the comparator group in the prior analysis. So this is the prior analysis. In the LIFE trial, they compared it with beta blockers. And there is some data, and of course these are observational, controversial data suggesting that beta blockers actually increase the risk of cancer. Then they compared, there were two trials where there was, they compared it against placebo, and you can anticipate that placebos do not increase the risk of cancer. They have one trial where the comparator was an ACE inhibitor, and there, again there is some data to suggest that ACE may be beneficial for the endpoint of cancer incidence. So quickly you can kind of see that this control group is not a homogeneous comparator. So there are some agents which might increase your risk, some which have a neutral effect on cancer, and some which will actually be beneficial for the incidence of cancer. So a direct comparator analysis, the direct or a traditional meta-analysis could be problematic. So we did a network, we actually did three different kind of analysis. One was similar to what the prior authors did, direct comparison analysis. We did a network analysis and a trial sequential analysis, and these are the results. And all three of our results showed consistent effect. So we had around 320,000 patients from randomized controlled trials, and we used placebo as the reference group. And if you use placebo, there was absolutely no increased risk of cancer with the ARBs, ACE inhibitors, or with any of the currently used antihypertensive agents. So based on, there is much more advanced meta-analytical technique which we will not go into, but our analysis refuted a 5 to 10% relative increase in the risk of cancer or cancer-related death with use of any of these agents. Now, so this is the tale of two meta-analyses. These two analyses were published in the same journal and 6 months apart, and they reached opposite conclusion. And the reason I showed this example is, so what was the difference? I mean, the analysis done by the prior authors were pretty rigorous, I must say, but there were differences. So they had only 8 trials for ARBs versus controls. We were able to find 21 randomized control trials. There are 93,000 patients. We had more than 120,000 patients. Of course, I mean, we used different kind of analysis, but we showed even using the one they used, the traditional analysis, we showed no difference in the incidence of cancer between the two agents. So this is the evidence pyramid. So lower down on the list, level 4 and 5 are anecdotal evidence, observational studies, and methodological verification studies. And up top on the list, level 1 evidence is for randomized controlled trials and also for meta-analysis. And when all available trials are included, systematic reviews and meta-analysis are considered to be the best available evidence. And this is the ACC-AHA classification of level of evidence. And as we see here, evidence based on a meta-analysis is a level A evidence. But I must add that they should include a word, well-conducted meta-analysis. So why should clinical cardiologists need to know about meta-analysis? This is a snapshot of what's going on in the publication era in terms of meta-analysis. Compared to 2001, we are almost 10-fold increase in the number of publications, and just last year, close to 14,000 meta-analyses were published. So it's highly likely that the next article you're going to take a look at will be a meta-analysis. So what are the characteristics of a high-quality meta-analysis? So I was told to talk about statistics, but there is a lot more to a meta-analysis, but I kind of like summarize it in this slide. So it's divided into what a typical journal article would look like, what to look at, methods, the results section, and the discussion. So some of the things to consider here is in the methods section, is the question quite explicit and well-defined? And we should take a clear look at what was the search. If there is anything about meta-analysis, I would say 95% of what is done in a meta-analysis relies on a good search. So the search should be comprehensive and systematic, and it should be reproducible. And data extraction, you have to make sure that the data extraction is explicit and it's, again, reproducible data extraction. In the methods, the authors will describe whether a quality analysis of each of these trials included in the analysis was included. And you have to take a look whether the statistical analysis employed was appropriate. We'll discuss more in detail in the next few slides. And the results, you have to see whether the results are appropriate. And the discussion, there is a trend to over-interpret data, so you have to make sure that the interpretation is actually supported by data and the authors have considered the limitations and strength of evidence. And finally, the author should describe about the implications for patient care and future research. So this is a typical forest plot. We'll take this as an example and walk through the different aspects of meta-analysis. This is a direct comparison or a traditional meta-analysis. So the forest plot will have the list of trials, usually arranged alphabetically. You have events, 75 events in the ARB arm versus 1013 were the total number of patients in that group, and events in the control arm. You have the weight of each of these trials and an effect measure. This could be relative risk, odds ratio, and the 95% confidence interval. In the middle, you'll find the forest plot, which has the square box, which represents the effect size for each of these trials. And the size of this box depends on the weight of each of these trials. So the larger weighted trials will have a bigger box compared to the smaller trials. And you see the 95% confidence interval. So then you have the random effects, the pooling of the data either by a random effects or a fixed effect model. And you see these are represented by diamond, and you see the corresponding pooled relative risk and 95% confidence interval. You see an I-square, here it is 50.7%, and a p-value for heterogeneity. So we'll discuss some of these issues in the next few slides. So what do you need to know while interpreting results of statistical analysis? You need to know whether there is heterogeneity, whether a fixed or a random effects model was used. Is there publication bias in the included trials? And what was the confidence interval and p-value of the effect size? So in terms of heterogeneity, I mean, it's a simple concept. It's variability among studies in the meta-analysis. So there can be actually different kind of heterogeneity. It could be clinical heterogeneity. There would be variability in the participants. Participants could have been enrolled in different parts of the world with different ratios of gender and ethical considerations. There could be variability in the intervention outcomes. There could be methodological heterogeneity. The studies could have variable design. But what we really mean in a meta-analysis is statistical heterogeneity. The statistical heterogeneity is the variability in the intervention effect. And many a times, if there is statistical heterogeneity, it could be from either of these two, clinical or methodological heterogeneity. A word of caution, though, if there is no statistical heterogeneity, it does not mean that there is no clinical heterogeneity. So how to identify heterogeneity? These are two forest plots in the interest of time. If you take a quick look at this, the plot on the left side, you see that the effect the point estimates of the effect size almost lie close to the line of unity here. So you can say that this is a meta-analysis with low heterogeneity, as opposed to this trial where you see the point estimate is in various different directions, and this is a meta-analysis with high heterogeneity. So if I were to ask everybody to visually interpret this, there could be a lot of subjectivity. So there are statistical methods of heterogeneity. One is the Cochrane Q statistics, and it assesses whether the observed difference is in results are compatible with chance alone. And a p-value, this is more of a qualitative metrics of heterogeneity, and a p-value less than 0.10 indicates that significant heterogeneity was present. We have an I-square percentage. It's more common nowadays to use I-square percentage because it's more of a quantitative measure of heterogeneity. And the higher the percentage of I-square, the greater the statistical heterogeneity. So what to do when there is significant heterogeneity? So if there is significant heterogeneity, and some people would say that do not combine if there is significant heterogeneity, and you can just do a systematic review and not a formal meta-analysis. Other people will say just ignore that, do a fixed effect model, but make sure that you discuss that in your discussion limitations section. You can account for heterogeneity by using a random effects model, or you can try to explain the heterogeneity by using subgroup analyses and meta-regression analysis. In terms of data pooling, so these are the two things you would see in meta-analysis. It's either people would have used a random effects model or a fixed effect model. Fixed effect model assumes that there is only a single intervention effect. So it basically assumes that if there are 10 different trials with different intervention effects, it assumes that the variation is due to random errors around the truth. And it pretty much evaluates the best estimate of intervention effect, and it ignores heterogeneity or assumes that there is no heterogeneity. Graphically, if you assume that this is a single true treatment effect, in a fixed effect model, all these random variation is assumed to be because of random variation around the single truth. Random effects model, on the other hand, assumes that the effect being estimated in different studies are not identical, but follow some distribution. So there are more than one truth, and it kind of incorporates heterogeneity among studies. It estimates the average intervention effects, and graphically put, these are the different truths, but the model is going to give us the average treatment effect of the model. So one of the major things of interpretation of a meta-analysis is publication bias. Of course, publication bias occurs whenever the research that appears in the published literature is systematically unrepresentative of the population of completed studies. And it can cause inaccurate conclusion in systematic reviews. So there are various different reasons why you can have publication bias. One is called the file drawer effect. There is data to suggest that the odds of publishing is 3 to 5 times greater for a positive trial. So this is one of the reasons it's really important to look for unpublished trials, contact authors for unpublished results. And we can see the difference between the two meta-analyses I showed before. The prior authors had 8 trials, we had 21 trials, some of which were unpublished, and we were able to reach out to those authors. The other publication bias could come from outcome reporting bias. So even among published journals, it's more likely that the significant outcomes are selectively reported than non-significant ones. And again, if you go back to the prior example I showed you, if there was no difference in cancer incidence between the two drugs, and if it was just a safety endpoint, people are less likely to present those results in the published manuscript. So it's really important to reach out to investigators to get unpublished data. The third type of publication bias is Tower of Babel bias. The non-English language authors may publish positive results in English language journals and negative results in non-English journals. So this is extremely important because if there is limits such as language limits to the search, you're most likely to leave out negative results and only have positive results. And then finally, there is the pipeline effects. Just like journals are reluctant to publish negative trials, authors also take a longer time to write up negative trials. So again, if you look at published data, it's most likely to have all of these positive intervention effects. Measures of publication bias, there is either, you can look at a funnel plot, and this is usually presented in the manuscript, and there are various other measures of publication bias. This is a typical funnel plot. It shows the study effect, and what we are looking for is an inverted funnel plot, and this is the central line. We're looking for symmetry around this central line. And again, there could be subjectivity around all of these visual estimate of publication bias. So there are various other statistical methods, the Eggers p-value and the Beck's p-value. If it is less than 0.05, it indicates significant higher risk of publication bias. In this, we see that the p-value is greater than 0.05, indicating that there is a low risk of publication bias. I think I'll skip all of this. So finally, going back to this interpretation of statistical results, so if you look at this, there are some journals, for example, the BMJ, they actually make you present both the random effects and the fixed effect model. Here, the random effects subtotal, if you look at it, the point estimate is 0.93. The diamond, the extreme arm of the diamond crosses the line of unity, suggesting there is no difference between ARBs and placebo. This was for a different question. So we were looking to see if ARBs are associated with an increased risk of MI compared to control agents. And again, the line of the 95% confidence interval crosses the line of unity. The I-square of 50.7 indicates that there is a modest heterogeneity. It's not a high level of heterogeneity, but there is some amount of heterogeneity. And the fixed effect model, again, shows somewhat similar effect size and confidence interval, suggesting that there is no difference between ARBs or placebo in terms of the intervention effect. So I think I'll skip these two. And finally, what a clinical cardiologist needs to know how to correctly interpret statistical analysis. The key thing, I think the top three things are search, search, and search. So more than statistical analysis, it's more of understanding the search and where could the possible limitations be from a limited search. I think it's important to understand if there is heterogeneity of included studies, is there risk of publication bias, and did the authors use the fixed or random effects model, and finally and most importantly to make sure that the interpretation and conclusion are actually supported by data. Thank you for your attention.
Thanks for your presentation, and thanks to all the people for coming to this session, and thanks also for the virtual audience.
Good, it was a pleasure.
A pleasure, a pleasure. Thank you.